I got into bioethics in the early 80s because as a medical surgical nurse, I was fed up with paternalistic practice. And I wanted to say to my physician colleagues, sit down, listen to the patient, listen to the family. Because we're doing things oftentimes that people don't want. We step out of their lives, they have to live with the consequences. Now, what, more than 20 years later, I'm coming back to my physician colleagues and I'm saying, stand up, be directive, issue a recommendation here, because all choices aren't equal. And we have reduced respect for autonomy and the right to be self-determining to this non-interference model of, here's a decision that needs to be made, here are your options, make it and we'll do it, oftentimes without concern for the outcomes of those choices and our role in making them happen. So I now say, and it seems like a simple sentence, but it's blasphemous, that the primary objective of all clinical decision-making is first and primarily to secure the interests, the health, well-being, good dying of the patient, and then to do that in a manner that respects or honors the integrity of every participant in the decision-making process. So I pull that in that way, but it says there's good medicine and good nursing and good social work and good psychiatry, and we can't abandon that practice simply because we're asked to do something. A doctor in Canada said to me, I like to think of myself as a technician. I own a skill, somebody buys it, and I use it. And I said, I'm so sad to hear that, because we're about more if we're committed to healing. And we are accountable for the outcomes of how we use the abilities that we have. So we're trying to teach here this model of shared decision-making that rejects the abuses of paternalistic practice and the abuses of patient sovereignty, and says we come together in the healing encounter, and we've got to discern together what truly will advance. And that's very different than me saying, you've got to do what I would do. It's not my decision. But it obligates me then to know who this person is, who this family is, so that I can work with them to help them realize their goals. I always think of a triangle, where the top point of the triangle are the numbers that equate with health or disease. If that's all we know, we can only do one-size-fits-all care. Base points of the triangle, how does their health state or disease state influence their sense of self, their family, and how do both influence their ability to achieve valued goals? Now, if I know the two base points, then we can do individualized, prioritized care, but always in a way that's consistent with good practice, good professional practice.